Good day, everybody. So this chapter is going to cover assessing the nutrition as well as anthropometric measurements. Nutrition is defined in your book as a state of balance between both nutrient intake as well as physiologic requirements for growth and health maintenance. This involves taking in and using food by which growth, repair, and maintenance of activities in the body as a whole or in any of its parts are accomplished. So there are a number of nutrients, number of minerals that the body needs in order to grow and to thrive. Nutrigenomics is research on how genes as well as diet affect a person's health and risk for developing disease. Weight loss can be a health benefit or could be a sign of illness. And we have to identify whether the weight that's been lost is intentional or planned or unintentional and unplanned. Your book goes into intentional weight loss in which the person reduces caloric intake by about 500 calories. And this could be related to diet intake. It could be related to exercising and really, losing fat, but not so much muscle. Where unintentional could be, involuntary loss of weight, could be related to an illness. It could be related to malnutrition related to protein and caloric intake. And sometimes we find that unintentional weight loss in the elderly when they don't have adequate food intake or they are not hungry, because as you get older, sometimes you lose your appetite, and so you tend to lose some weight. There is obviously malnutrition. There's nutrition, which you're getting the balance of, nutrients and supplements. But then there's, malnutrition that can be defined as either overnutrition or undernutrition. And overnutrition can be frequent or it can be habitual consumption of nutrients. And this is really eating more than the body needs. A greater amount of caloric intake than is what is required of the body for daily. Overnutrition can also result from inactivity or having a sedentary lifestyle, genetic factors, and there are other medications such as antidepressants that can increase appetite and cause a person to want to eat more. Undernutrition is defined as not gaining the adequate nutrients and supplements that is needed. It can be caused by a reduction in caloric intake. Maybe persons who wants to go on a diet goes in excess of that diet and overdoes it, where they've limited their caloric intake or they've limited a supplement that's necessary for their body to grow and to thrive. So let's begin with a clicker check. So you're interviewing a 63-year-old male, and they say they're going to buy all new clothes because the clothes are getting too big. They deny that they've been dieting or have a decrease in appetite. What is this an example of? Is it A, intentional weight loss, B, unintentional weight loss, C, overnutrition, or D, malnutrition? If you picked B, if you picked B, unintentional weight loss, you're correct. So the person might be losing weight without really trying to do so, and this may be a sign of an underlying disease or some psychosocial or physical disability that's preventing them from getting the food that they need. So diagnostics that go alongside identifying someone's nutritional status will include a complete blood count, and a CBC is your typical blood draw that will identify whether the person's anemic by looking at their hemoglobin and hematocrit. We can also identify, how severe their anemic status is by looking at the mean corpuscular volume and the mean the hemoglobin, as well as what their coagulation status is by looking at their platelet count. Vitamin D deficiency could be related to a deficiency of vitamin B12 being absorbed by the stomach or the intestines. So one of the other labs we would include is to determine, well, are they able to absorb? Are they intaking vitamin B12? What are the sources of foods that they're taking in? And then is their body able to absorb it? Folic acid or folate levels, it's really hard to find folic acid in a lot of foods, but some foods are fortified with folic acid, such as bran cereals, orange juices, just to name a few. And folic acid is pretty important for the red blood cell as well as white blood cell function. So folic acid is necessary. In pregnancy, it's also necessary, especially during preconception counseling, because lack of folic acid can lead to neural tube defects in fetal development. Ferritin is a protein that is manufactured in the liver as well as in the spleen and bone marrow, and it's important for the body's needs in terms of iron absorption and intake. Prealbumin and albumin really are more so proteins that are necessary for muscle and growth, muscle development as well as bone development. And there are some religions or cultures in which there are certain foods that are forbidden, or there are some cultures in which it's strictly a vegetarian diet, or it's a diet in which certain foods are not allowed to be consumed. So it's important to be culturally competent and understand, number one, what population are you working with, and number two, what foods are popular and what foods are forbidden for consumption, and how does that play a role in the current patient's diet. So obviously we always want to get a full health history from the patient in terms of where they are on that health spectrum, on their nutrition spectrum. So we want to identify food preparation. Who prepares the food? How is the food prepared? Do they have the supplies needed to prepare a food? Do they have a refrigerator, a stove, a microwave, a toaster oven in order to help prepare the food? So where they live and what do they have? If they're not able to prepare food for themselves, who is then preparing their food for them? And if there is no food preparation, then how are they getting their food? You also want to find out, have they lost or gained weight over time? Have they noticed a change in their weight? What are their dietary preferences? And with that, you want to also know what are their religious and cultural values, and how does that meet their dietary preferences? Are there any foods that they're intolerant to? Do they have any food allergies? Are they supporting their nutrition by taking any supplementation? How much water are they drinking, if they're drinking any water? Really more so, what beverages are they consuming, and then break that down into, if they're drinking caffeinated beverages, how much, and how does that equate to water intake? Because water is about 60, to 70% of your body, so you need to consume water to replenish what you lose through sweat or urination or respiration. Find out what type of appetite they have. Anorexia, it could mean just, do they have anorexia nervosa, which is just an intentional lack of eating to control body weight and body image, or are they anorexic because of, say, chemotherapy, or some type of illness, or some type of mental illness as well. Sometimes mental illness can cause anorexia. And other appetite, disorders such as, I'm just going to look these up really quick for you, just because I always blank on the terminology with these eusias, the agusia as well as dysugia, and dysphagia. Dysphagia is just difficulty swallowing. So this clicker question is: your patient reports a poor appetite for the past month. They state that food has no taste anymore. What medical term would you document in your note? Is it anorexia, aphasia, ageusia, or dysphagia? And the correct answer is ageusia, which is the absence of taste. And a lot of this has really come out around COVID, where people who developed COVID also, lost that sense of taste, and so this came along with it. The other term, the dysphagia, refers to the presence of, say, a metallic or rancid or foul taste in their mouth. And that really goes along the lines of, well, if they have that taste and they don't really, enjoy the taste of food, and they have a difficulty enjoying a taste of food. So the next question is: the nurse is assessing an overweight patient who states, "I don't have much of an appetite anymore." Which statement by the nurse represents their best response? And remember, this is therapeutic communication. So is it, do you make your own meals? Well, it would help you to lose weight. What foods do you like to eat? When did you start to lose your appetite? And the answer is D. The patient is sharing with you that he or she is anorexic, that they're not eating as well as they used to. So you really should go through that whole health history of it, the old carts, the PQRST. So when did it start? Tell me more about what is going on. So there are a ton of nutritional screening tools, and these tools help to screen patients at nutritional risk in a short amount of time. And your book has a couple of these screening tools. One example is the dietary recall, which is in box 4.2. And a dietary recall pretty much asks the patient, from the time you get up from, bed till the time you go to sleep, tell me about what your typical, daily meal is. What do you have for breakfast? Are there snacks in between, breakfast and lunch? What do you usually have for lunch? Do you snack in between? What do you have for dinner? When do you have dinner? How much of the dinner do you have? Do you have a snack before you go to bed? So you're kind of going through all of these recalls. And these tools help to assess, what is there a diagnosis? Are they only eating breakfast and they're not eating the rest of the day? Do they find that they have more of an appetite in the morning versus in the evening? Or do they find they skip both breakfast and lunch and then have a large appetite and, and eat in the evening? What is their nutritional intake like? If they're not getting, say, the protein from eggs in the morning, are they getting it in the evening with, a hamburger or some type of protein-based meal? Do they have symptoms that are preventing them from having an adequate, daily intake? Do they have symptoms of diarrhea, vomiting, hyperemesis, which is just an increase in vomiting, an increase in the sensation of nausea? What do they consider their ideal body standards to be? And then what has their weight history been like? Have they struggled with weight gain or weight loss? Assessing a patient's nutritional status is also based on a physical assessment, and that includes that full head-to-toe physical assessment along with those anthropometric measurements, the measurements of the waist, the hip, the arm circumference, the labs, as well as just that give and take general discussion with the patient. So we're collecting our our objective information. And the purpose is really to gather both physical as well as psychological signs, if there are any, of malnutrition. And to begin our assessment, our physical examination, we're going to need a couple of things, including a paper tape, a scale, as well as a meter that's going to help to measure certain body parts, which I will get into. So the first thing we're going to do is really do that inspection. So we talked about inspection, and we're looking at, their demeanor. We're looking at their hair, their eyes, their lips, their tongue, because those really will tell us, what their hydration or dehydration status is. We're looking at their teeth when we're doing a mouth assessment, and it's going to kind of go hand in hand with our HEENT, which we're going to cover in a week or two. We're looking at their teeth, their gums. We're going to talk about the integumentary system as well. Looking at their skin, nails, and the mobility of their skin, and that's going to help us determine, if they're hydrated. Their skin coloration can also tell us if they're anemic or if they're paler. We want to assess a nutritional history to really identify baseline dietary patterns. And again, going through the last 24 hours, what is their typical dietary intake? When do they usually eat meals of the day? What meals do they eat? What size of meals are they able to complete the entire meal? And do they include beverages with their meals? And as discussed in a few slides ago, it's that dietary recall that should really be a part of your nutritional assessment of the patient. Through direct observation, we want to identify how much food they're eating, maybe observing the patient eating during mealtime if they're hospital bound or if they're in assisted living and we're conducting a nutritional assessment on them. Identify, what do they have? Are they having difficulty swallowing or feeding themselves? Do they have mobility issues? Do they have dentures or caps or missing teeth in their mouth that's preventing them from adequately chewing? Do they need their food minced up, crushed, pureed, or liquefied? And how much are they eating? And normally patients should eat about 75% of their, food intake. With anthropometric measurements, we are, using certain tools and identifying measurements to determine, physical dimensions as well as the amount of subcutaneous fat that a person's body has. And the first assessment is the BMI, which in which you take the patient's height as well as their weight. So the assessment of the BMI is described in detail on page 58 as well as 59, along with the normal findings. And remember, body mass index is based on the height and weight of the patient. However, it's not always as accurate because somebody who is very super muscular, like The Rock, may have a really high BMI. It doesn't mean that he's overweight. It just means that that added weight is more so the weight of his muscle. The normal BMI is between 18.5 and 24.9. Underweight, overweight, obese, as well as morbidly obese are where we would fall under the abnormal findings. Assessing abdominal circumference, that's something in which we're going to use a paper tape or a measuring tape to help identify a patient's abdominal circumference and the amount of abdominal fat that they have. The more abdominal fat a patient has, the more at risk they are for comorbidities such as diabetes and hypertension. The normal findings will vary between the male and the female population. Where male population, the normal finding should be about 40 inches around, and it should be right around the umbilicus or the belly button, and the iliac, at the level of the iliac crest. And then with a female, it should be about 35 inches. And these are the measurements and abnormal findings. And again, an increase in abdominal circumference means an increase in subcutaneous fat, which then puts that patient more at risk for a comorbidity. Okay, so let's take a question break. So a patient is getting his annual physical exam. The patient is 6 feet 2 inches and weighs about 200 pounds. Calculate their BMI. If you calculated 26, you're correct. And with 26, you know that this patient is considered overweight. So waist to hip ratio, this is where you would place the measuring tape around the narrowest area of the waist between the hips as well as the 11th rib. So kind of figuring out where that floating rib is in the back. Take a measurement after a normal breath has been done, where the patient's not fully exhaled but is in that kind of relaxed state, and then you'll measure in centimeters. And you'll place the measure tape at the hips at the widest point, record the measurements again in centimeters, and then calculate dividing the waist measurement by the hip measurement. And your book on page 61 goes into more of a visual as to how to conduct that measurement. And just kind of a tip from the book, that fat distribution can result in a pear-shaped figure or an apple-shaped figure. So just knowing, the ratio between where the waist and where the hips will kind of give us information on their risk for cardiovascular disease or type 2 diabetes. We also want to assess the mid-upper arm circumference to determine their body protein as well as skeletal muscle mass. For this, we'll need a measuring tape and a marker. In this measurement, we want to measure their upper arm circumference, and this kind of gives us an indicator as to their nutritional status. If we're not able to do other measurements, this is another measurement that we can certainly include. You should really measure without any clothing. The patient shouldn't have any clothing on their arm or upper arm. It should really be a bare arm or bare skin. You're going to use the measuring tape, measuring from the top of the shoulder to the tip of the elbow, and then identify the midpoint of that measurement, and you'll mark that point. Okay, so it should be right around that deltoid region, and have them relax their arm at their side so that it's not tense. You'll measure the arm in centimeters at that midpoint, and you want to make sure that that measuring tape is not tight but somewhat snug, where you're able to introduce maybe a finger or pinky in between. And the normal measurements should be greater than in the male 23 centimeters, and in the female greater than 22. Anything less could indicate a loss of protein and muscle mass. All right, let's do another question. So you're assessing a waist to hip ratio on a patient. After placing the tape measure around the narrowest area of the waist, when do you take the measurement? Is it as the patient breathes in, as they breathe out, at any time, or does breathing not influence this measurement? If you answered B, you're correct. They should breathe out and then relax. So Healthy People 2030 goal for nutrition is to improve health by improving healthy eating and making nutritional food choices. And MyPlate provides a visual of the 5 good groups to eat, including breads, fruits and vegetables, and dairy. Water intake, again, very important source, as it is a part of every major tissue in your body, and water is about 60 to 70% of your your total whole body composition. And you certainly look for signs of dehydration by doing a skin assessment and looking at their mucous membranes and their lips, if they're cracked or dry. You're also assessing their water intake by looking at their urinary output. You can do a urinalysis and identify the specific gravity to determine if they're dehydrated. Sometimes if they have a lot of ketones in their urine, they're very dehydrated. And then dehydration can really result from severe nausea and vomiting. Weight loss does take time. It's a lot of hard work. And there's a tremendous amount of patients. So the patients who are in the overweight or obese, who are looking to, lose weight for health reasons, really need to be educated on how to read nutrition labels. They should also get into newer habits, such as increasing their water intake and decreasing any caffeinated or soda products. Portion size is also important, and nurses play a vital role in this type of education. Any use of alcohol is really, could be empty carbs right there. So just reducing or decreasing or eliminating alcohol and increasing exercise are crucial for a healthier lifestyle. So let's start with this next question. A 90-year-old female patient is bedbound and immobile. Which of the following is the best method to assess body protein stores and skeletal muscle mass in this patient? If you answered B, you're correct. The RN is working in a long-term care facility and knows that an 82-year-old patient is losing weight. What will the RN assess during mealtime? Is it A, note if they have dysphagia, B, observe if they're eating during their mealtime, C, calculate the percent of intake, or D, all of the above? D, all of the above. The nurse should observe the patient during mealtime and note if the patient's having any difficulty swallowing, documenting the percent, and typically there should be about 75% of their meal eaten, and identify if they're having any other issues consuming their meal.